Hi, I'm Dr. Simon Freiler, consultant in clinical neurophysiology, and in this video I will talk about sporadic inclusion body myositis, or IBM for short. You might also be interested in seeing the other video about 3 other important causes of myositis by following the icard above. I've intentionally separated this one away from polymyositis, dermatomyositis and necrotizing myositis because it is very different. Clinically, it tends to affect older people above the age of 50, and it occurs in around 5 people per 100,000. Unlike poly and dermatomyositis, it affects men 3 times more than women. It is a much slower disease that can often be asymmetrical, and it progresses slowly and painlessly over many years. Impaired swallowing is a clinical hallmark which can even precede arm and leg involvement. Unlike the typical myopathies where proximal muscles are affected, in IBM the forearm muscles that pull the fingers into the palm and the leg muscles which help straighten the knees are preferentially affected. Mobility tends to decrease slowly, with patients usually beginning wheelchair use around 15 years into the condition. Despite the significant disabilities, life expectancy is relatively unaffected. The key to diagnosis is a muscle biopsy, where in addition to the presence of similar inflammatory cells to polymyositis, namely macrophages and CD8 positive T lymphocytes, there are also ringed vacuoles and intracellular beta amyloid deposits which are highlighted with Congo red staining. Other neurodegenerative proteins, such as tau proteins, can also accumulate. This leads researchers into a conundrum as to what the cause of IBM actually is, namely, is this primarily an autoimmune inflammatory condition, or is it a degenerative one, or both, and could there be a genetic predisposition to sporadic IBM? In fact, IBM tends not to respond to many of the immunosuppressing or immunomodulating medications that are currently used in the other inflammatory myopathies, which lends support to the degenerative hypothesis. Apart from muscle biopsy, it is important that clinical and biochemical features are integrated too. Neurophysiologists such as myself can look for evidence of myopathy and the pattern in which muscles are affected. You can see a separate video explaining some of the salient features by following the icard above. In around 1/3 of patients there is also an associated peripheral neuropathy. It can at times in the disease course be quite challenging for us to distinguish this condition from motor neurone disease, and so on occasion interval testing might be required. In terms of treatment, current options tend not to modify the disease course, although individual patients may benefit briefly. Whilst there is evidence for the role of IVIG in treating problems with swallowing called dysphagia, there is no evidence it helps increase general muscle strength. A number of clinical trials with other medications remain ongoing. Dysphagia can be uncomfortable and distressing for patients, and can also lead to problems such as malnutrition and chest infections from misswallowing. This is called aspiration pneumonia and is an important cause of mortality. Management of dysphagia will need liaison with gastroenterologists and their surgical counterparts. Cricopharyngeal myotomy, upper esophageal sphincter Botox or dilatation, and peg feeding are all considerations. And of course, integrated care with rehabilitation specialists, dietitians, physiotherapists and occupational therapists is necessary. Appropriate exercise should be encouraged and can benefit muscle function. I hope that you have found this video useful, and if so, please support this channel by subscribing and giving a thumbs up. Many thanks.